remember as an intern, back in 1997, as a family medicine intern, when I first came into this country, I immigrated from Lebanon at the time. And it's so great to see Dr. Steve Spand here, who was at the time the chair of family medicine at Baylor College of Medicine. And he used to show us lots of slides about healthcare costs and stuff. And I knew very little about them at the time. But what we've seen over the years is that those healthcare costs are continuing to be the exact same, and that same exact trajectory or same exact trend. I'm assuming most of you here in this audience have seen the slide where our healthcare cost is pretty high up per capita compared to our life expectancy when we look at other countries across the globe. So we continue to see that trend that we're paying a lot for healthcare and we're getting less in return. This is the CMS projection of expenditure, where we see that we're expecting an increase of an average 5.7%, which is 1.1% faster growth than the GDP. So we're spending around, as a country, somewhere between, closer to $3 trillion in healthcare per year, and that trajectory is continuing to grow in a way that won't be sustainable. If you take just our healthcare expenditure as a country, we're just the healthcare expenditure, we're in the top 6 largest countries in the world, just on the healthcare expenditure side. We're expecting to be a good chunk of our GDP, and that number continues to grow. We're expecting it to be at somewhere around 19.3%. By 2023. And even when you hear from folks at the Congressional Budget Office and at the White House, if that growth of Medicare and Medicaid expenditures continues to grow at the same pace that it grew for the last 40 years, if that pace continues to grow for the next 40 years, we're expecting our expenditure on Medicare and Medicaid alone to be bigger than the federal government today by 2050, which is this is clearly non-sustainable. We're also seeing a significant growth in our senior population. We're expecting 76.4 million baby boomers in the next 20 years. This is 3 million baby boomers every year that's coming up into the United States. And when you look at all the other, most of the associations, when you look at numbers from them, it really tells you that our healthcare expenditures are going to continue to go up unless we think more creatively about it. And then there was something called the Affordable Care Act that I think some of you might be familiar with. That's really pushing us to start thinking more about population health. And when you think about healthcare systems today, or 4 years ago, that we're really focused on how do we produce units of service, and how do we make sure that we're billing for those units of service, and really shifting to tomorrow's environment where we're looking more at population health and looking more at the total cost of care, looking more at the triple aim, at empowering individuals within our communities to achieve the triple aim. You're starting to see that shift that's happening in pretty much every one of our healthcare system across the country. This is kind of where the dividend, I think, comes in. If we continue being a producer-centered as health systems, our healthcare costs are going to continue to go up. But if we make that shift towards population health management, and hopefully we'll be able to curb our expenses on the healthcare side, we're going to have that dividend. And we could think about lots of ways to investing that dividends in, from sharing some of that shared savings with providers and healthcare systems and payers, but most importantly, putting it back into freeing up some of these dollars in the economy. Since this is a practical playbook, I figured that the majority of this presentation will be practically how we as a health system are helping with that shift, or are embracing that shift from healthcare to population health. So the next 15 minutes or so will be just exactly some specific examples of how our system as Trinity Health is taking that paradigm shift and is excited about it. So just a brief overview about Trinity Health. We are in communities serving more than 30 million people across the country. So we have a pretty wide footprint in the United States. And when you look at our mission statements, we are all about transforming communities. And I know a lot of folks, when they think about healthcare system, we think about a system that's treating illness. But when you look at the mission of our organization, you know, our pioneers, our founders, these very bold, courageous nuns that went to low-income communities and started providing services, they were not necessarily just about providing healthcare services. They were about transforming that communities, those communities that they visited. So transforming communities is the heart and the core of our mission as a system. And even when you look at our core values of reverence and commitment to those who are poor and justice, it's really all about that community transformation that's important. So a couple of years ago, our board of directors came together and spent a lot of time talking about that shift from a healthcare to a population health environment. And basically what they came up with is that for us to become a people-centered system, we really need to be focusing our efforts on three main areas. We're going to continue to do episodic care, and this is something that we've done for 160 plus years, so we're going to continue to do that. We're going to build a lot of capabilities on population health management, and we're going to talk some very specific examples of what we're doing around population health management. But then we also wanted to make sure that we're looking at community health and well-being as an integral part of our work as a system. And a couple of years ago, our board of directors made that commitment to say, we're going to become people-centered system, and to do that, we're going to need to be focusing on these three pillars. So I'm going to talk about each one of these pillars with some very specific examples of what we're doing in each one of those pillars. So let me start with the episodic healthcare work. And to give you a snapshot of where we are, we're in 21 states right now. We have a network of 92 hospitals. We have 47 home care and hospice programs, 59 continuing care facilities. We are one of the largest PACE providers in the country with 14 locations. And for those of you who are not familiar with PACE, it's a comprehensive primary care with lots of wraparound services for seniors living in poverty, and they're mostly dual eligible patients. We have a network of 4,000 or so employed physicians and 24,000 affiliated physicians. So our footprint is pretty significant when it comes to the episodic care that goes all the way from the East Coast to the West Coast. And one thing that we're doing in that shift is we really embraced the bundled payment for care improvement programs. How many of you here, with a show of hands, is familiar with the bundled payment for care improvement programs? A good chunk of you. So the folks who are not familiar, I really encourage you to look into those this program. And this is basically where, in our case, our hospital system is taking responsibility for the 90 days of care for that very specific episode. So we are one of the largest bundled payment for care improvement program in the country. We are adopting 43 or so bundles. So we look at, orthopedic bundles, there's cardiovascular bundles, sepsis bundles, all of these different types of bundles. And then we are coming to the CMS and telling the federal government that we will be accountable for the 90 days, the complete total cost of care for those 90 days of that patient episode, whether it's a knee replacement or a sepsis episode or a congestive heart failure episode. And what that drives us is, all of a sudden, as a health system, we have to be responsible, and we have to be very careful on what happens to that patient, not just within the four walls of the hospitals that they're in, those 4 days, 5 days, 3-point-some days. We're really looking at the 90 days. So we want to make sure that transition from the hospitals to the SNF to home, all of those are really well coordinated. So it's pushing us as a system to think about that full 90-day episode. So even on the episode side, we're really starting thinking about the overall health of that person that goes beyond the four walls of the hospital. So lots and lots of work here around bundled payment. And for folks who are involved with that work, it's a lot of work. It's very, very hard work. And for us, this is around $550 million out of our overall budget. It's a smaller portion of our overall budget. We're around $16.5 billion operations, but it's really taking that push to get us to think more beyond just traditional hospital work. On the population health management side, we've been building the capabilities to look at those patients whose lives are attributed to us and try to see what can we do to make sure that we're empowering these individuals to achieve the triple aim. We want those people who are attributed to us as a health system to have better care, better health, as well as lower cost. So throughout this process, we've invested since June of 2013, we've invested over $90 million in building those capabilities within our system. We've built lots of accountable care organizations. We've actively participated in Medicare Shared Savings Program and Next-Gen ACOs, and we continue to grow the number of lives that are attributed to our system. So when you look at our footprint, pretty much in every one of our communities, we have an accountable care organization. We are actively participating in 14 of the Medicare Shared Savings Program with CMS. 5 of our markets have Next-Gen ACO, which is the new version of the Medicare ACO. We participate in almost 100 of non-CMS value-based contracts with providers. So even on the private sector, we're also embracing the alternative payment models for our contracts with payers. Right now, we have around 14,000 or so providers participating in our clinically integrated networks, and we have around 1.2 million attributed lives to our health system. What that tells us is, as a system, we're embracing the care for those 1.2 million patients beyond the fee-for-service environment, beyond just ordering CAT scans and mammograms and MRIs. We're taking full responsibility of those 1.2 million people's lives and making sure that we're trying to lower costs, improve health outcomes, and improve care for them. So when you look from our experience in the first 2.5 years or so that we've built this infrastructure, so in FY14, when you look at our overall investments in our accountable care organization, we're at around 16.5 million, but we've generated revenue, a total of savings of around 44.2 million. Now, the majority of the savings is still going to the payers, but we were able to get enough shared savings to at least cover our costs. And that investment that we're doing, we're really convinced that this is the right way forward to allow us to create that shared savings and really to allow us to achieve the triple aim for those attributed lives to us. So lots and lots of work on the population health management side. You'll see kind of our philosophy of our approach there. It's all about reducing unnecessary and avoidable hospitalization. It's about making sure that we have standardized care management processes in place, minimizing, really working on the post-acute side of the work and really building our infrastructure around IT, data analytics, and predictive modeling. So lots of work is happening on the population health management side. The third pillar of our work is really around community health and well-being. And I know that, when I transitioned from my role in public health at the health department in Chicago to the health system, I'm like, why is not my title in population health? And I've realized that actually population health management and community health and well-being are, have different connotation within health system. So while I do a lot of work with population health management team, the work around community health and well-being is kind of integrated, but it's really kind of distinct, if you want, from a health system perspective, and I'll talk a little bit about that. So when I was first recruited to lead our community health and well-being effort at the health system, traditionally health systems look at their community health work from the community benefit lens. And it was important for us as a system to take a step back and say, let's reimagine community health from a health system perspective. What would that look like if a health system like ours, one of the largest in the country, decides to say, we want to be part of transforming communities? What would that mean? So we spent a lot of time, the first couple of months, 3-4 months that I was at the health system, talking to our board members, talking to our leaders internally, but also talking to a lot of my public health friends that I've had before moving to the health system, and I'm glad I still have them. They didn't abandon me yet. But, thinking about what does it mean for us to be in the community health and well-being space. So this was actually the framework that we came up with. And we said that if we wanted to be a health system that's really engaged in community health and well-being, we need to think about it also along three different areas of focus. We need to continue to look at the clinical services, especially for people living in poverty within our system. So what is it that we're doing for our patients who are on Medicaid? What are we doing for dual eligible patients? How are we looking at those who are uninsured within our system? How are we leveraging our clinical environment to advance prevention and public health efforts and initiative? So that really falls within that clinical services bucket. And I'm going to give you some, again, very concrete examples of what we're doing in that space. But then we also said that if we, dealing with patients who are living in poverty requires a lot more than just prescribing medications and making sure that people are getting their clinical services. It's really about the wraparound services. So how, as a system, we look at those patients of ours who are our own patients who are living in poverty and make sure that we're creating environments and systems in place to create these wraparound services for them when it comes to social services. So we have a whole set of activities under that community engagement bucket of our work. And this is really around the interface between our health system and social services agencies across our communities. But then we also said that, as we move more and more towards a pay-for-value environment, we need to be really engaged in the built environment. We need to be really engaged in engagement with other with other sectors like transportation, like community development. We need to look at education, and we need to figure out how do we fit in that community transformation space. So that was the third bucket of our work. And across this continuum, how do we think about innovation in our care delivery model, and how do we make it happen? How do we think about innovation in technology, whether it's through app development, use of predictive modeling, and other technology tool? And really, how do we think about innovation and financing that goes beyond our community benefit pool, which is a lot of money. We invest around $1 billion in community benefits every year across the system, so it's a lot of money there that we could think about more creatively. But really, we need to start thinking about pay-for-success models. We need to be thinking about social impact bonds. So how do we bring that together? So that was kind of our framework that we've developed. I think it was approved by our board back in June of 2015. And we started doing lots of activities on each one of these buckets. So, on the clinical services, I'd like to highlight one group of patient population that I'm spending a lot of time trying to understand and think about, and those are the dual eligible patients. How many of you are familiar with dual eligible patients? Okay, overwhelming majority, that's great. So this is around 10.7 million people in this country. These are seniors living in poverty and people with disability living in poverty. When you look at this patient population, these are amongst the poorest with the most complex medical needs, and a significant proportion of them, almost half, have significant mental illness. And when you look at their healthcare costs, it's pretty significant. You look, it's again, it's around 10.7 million people, and we spend 2% of our overall GDP as a country just to provide healthcare services for these 10 million people. 2% of the GDP of the richest, I don't know if that's a word, country in the world. And that's just to provide healthcare services for these folks. So lots of opportunity, and you think that we're spending that much money, they're going to have great outcomes. Well, the reality it isn't. So as part of our work in the community health and well-being space, I spent a lot of time trying to understand this patient population within our system and try to see how do we optimize the care for these folks. And now across each one of our systems, regional systems across the country, we have teams that's looking at trying to understand the dual patient populations within their market, understand best practices for them, and really look at innovative ways to optimize the care for these folks. And we've done that same kind of exercise from across the system office, looking at each one of our regions, try to see what is this patient population, how are we providing care to them, how can we optimize the care for them. We have around 207,000 or so, probably close to 225 once you add the continuing care locations. So let's say 225,000 dual eligible patients within our system. That's almost $6 billion in total cost of care. So there's a huge opportunity for us to think about this patient population more carefully. And just recently, we've launched an innovation challenge, because when we look at this patient population and did the deep analytical dive into this patient population, we've realized that in our Medicare Shared Savings Program and NextGen ACO, the readmission rate for dual eligible patients is almost twice as high as it is for those who are non-dual eligible patients. And when we looked at the bundled payment for care improvement program, the readmission rate for dual eligible patients within our bundled episodes across the system is 37% higher than it is for non-duals. So we've launched this challenge, and for those folks who are tweeting, please, this is the perfect opportunity to tweet this link, where we're asking folks to actually come up, and internal partners as well as external partners, to come up with innovative solutions to really try to impact the readmission rates for those who are dually enrolled within our accountable care organizations or our bundled payment for care improvement programs. We're really excited about this. We're thinking we're going to be able to generate a large number of innovative solutions. And the interesting part about this is, you know, it's not just a challenge to kind of identify ideas and give a prize for the best idea. The commitment there, our $2 million commitment, is to take the best ideas, up to 6 of them, and roll up our sleeves and implement those interventions in our accountable care organizations, and not just for 3 months or 6 months, for a total of 18 months, and then track the outcomes of admissions and readmissions and see if we can make a difference there. So we're really, you know, embracing the concept of the clinical services for low-income individuals in this country as part of our community health and well-being strategy. The second piece that we talked about, and this kind of goes in line with that innovation challenge, is finding those wraparound services and thinking about what is our role as a health system and embracing the relationship between the healthcare system and the social services agencies. You know, this is also would be no surprise here to anybody in this room. We strongly believe that access and quality of care really is not all what drives health outcomes. So that's why we've been piloting different models across our system to try to see how do we create that interface between healthcare and social services agencies. One of the model is in Muskegon, Michigan, and West Michigan. It's called the Hub model. It was funded by CMMI, where we actually have funded, I think, 36 or so community health workers, placed them in social services agencies, and created this hub. This is not a virtual hub, it's an actual hub, like an office, where a hub coordinator is taking phone calls from our emergency department, from our physicians, from our nurses, care coordinators, to make sure that our own patients who need those wraparound services are connected to the appropriate community health workers in the communities. But at the same time, that hub coordinator is also taking phone calls from the police department, the fire department, the libraries, when they see they interface with people who might need that linkage to the healthcare system. So creating that interface between the social services agencies and the healthcare system through that hub office has been a great model for us to actually pilot and learn what would it make, how can we make a difference in the social services needs of these folks. And what's different about this model is our community health workers are not housed in the hub office. They're actually housed in the social services agencies. So these community health workers go to work at the social services agencies, and they coordinate with our health system. Lots of great stories there. We continue to see, you know, better health, better care, but also lower costs. And this is Keziah and Katrina, who Keziah was born to a mom who was experiencing homelessness at the time, and through working with the community health workers, we were able to provide the right wraparound services for her. We have different models across the system. This is kind of the hub model is probably our most advanced community health worker model, but we are committed as a system to embracing community health workers' role within our accountable care organizations, within our hospital system, but most importantly, in working relationships with the social services agencies in our communities. And just last year, we've entered into a partnership with the Corporation for National and Community Service, which is the organization that administers the AmeriCorps program, and we are hiring, training and deploying 50 AmeriCorps members as community health coordinators, and we're placing these AmeriCorps members in our accountable care organization infrastructure, working hand in hand with our medical care managers across the system. And we're piloting with 5 communities. I think I saw Andrew Missel on my team here. Andrew, if you're here, raise your hand, who's kind of running that program for us. I don't see him here. Oh, there you are. Yep. So Andrew is coordinating with a group of folks on my team the deployment of these community health coordinators, these AmeriCorps members as community health coordinators. And you know, to work specifically with dual eligible patients, again, as we kind of keep that theme of people living in poverty, we want to make sure that we're creating that connection for seniors living in poverty or people with disability living in poverty. And a couple of the things that we've been thinking about is as we continue to focus on working with seniors, the AmeriCorps members who we would like to recruit are not necessarily the traditional AmeriCorps members that you would think about. You know, kids getting out of college, want to do a couple of years of service, and they'll be AmeriCorps members. We're going to be even trying to focus on seniors who are, you know, still have a lot to offer the communities and can be AmeriCorps members and provide that wraparound service for duals and other seniors in the system. So we're really excited about this effort. We have identified the 4 or 5 communities where we'll be launching this effort as we continue to look at ways to replicate our hub model that we have in Muskegon and other parts of the system. And one key element that's important is how do we measure the impact of these interventions? And because we're focusing these efforts on our accountable care organizations and on seniors who are, you know, on dual eligible patients who are part of our accountable care organizations, we have total cost of care on them, we have clinical quality outcomes on them, we have care experience outcome on them. So we will be able to evaluate the triple aim outcomes of these individuals who end up being involved with us through that effort. So we're really excited about that. And then finally, I want to give you just a snapshot of some of our work around community transformation. And again, for this group, this is no surprise. We strongly believe that health does not begin in the 4 walls of our hospitals or in the doctor's offices. So that's why we've launched our Transforming Communities initiative back in November of 2015. And what we said, we're going to take $80 million, package it between loans and grants, and we're going to identify 6 communities across our footprint and say, what would it take for us to work with community coalitions to transform those communities? And we've identified 6 of those communities. In the request for proposal process, we asked to have 3 signatures on every one of these applications. We wanted the community coalition lead that will be actually receiving the funding and doing the work to be the main applicant there. We wanted our hospital CEO in that market to be the second signature on that application, and we wanted local public health or state public health, depending on the situation, but mostly local public health to be the third signature on that application. Because we strongly believe that unless you have the community coalition that's leading this work, it has to have the support and the buy-in of the health system. That's why our CEOs need to be there, but also the local public health needs to be an integral part of this effort. And we've identified 7 technical assistance partners to be able to provide technical assistance to these 6 communities. We have Georgia Health Policy will be leading the evaluation for us. Community Catalyst will be bringing the community's voice into these efforts. Campaign for Tobacco-Free Kids are our partners around tobacco work. Change Lab Solutions is actually our technical assistance partners on the policy systems and environmental change. And I think I saw Maris, the CEO of Change Lab Solutions. She's right there. Make sure you talk to her. Does great work. So we're really excited about Change Lab being our national partner in this effort. But we've also brought in 2 CDFIs to really help us think about how community development and community health interface. So we are very excited about the Reinvestment Fund and IFF, 2 community development finance institution, to help our communities look at how do we really spend grants, loans that we could make available to those communities. So as part of this effort, the $80 million, $40 million is available in grants and $40 million is available in loans, and low interest or no interest loans to those communities, so that we can look at how do we look at housing? How do we look at food access? How do we look at early childhood education? How do we look at access to primary care in low-income communities, and really empower these communities to tap into our investment portfolio, really, and tap into these $40 million available to them in loans, and IFF and TRF will be helping these communities in that process. The 6 communities that we've identified are the 3 S's: the Syracuse, New York, Springfield, Massachusetts, and Silver Spring, Maryland, Maywood/Chicago, Trenton, New Jersey, and Boise, Idaho are our 6 communities that we've decided to invest resources in the next 5 years. And I think the fundamental shift there, and I know there are many funders here, we didn't go to these communities and said, we'd want you to do this. We went to these communities and said, we want to identify the community coalitions there, and the community coalitions there need to tell us what they think they'd want to do when it comes to tobacco, obesity, and healthy living, and we're there to support their effort. And this is a fundamental shift, and for our board to say, yes, we'll take those $80 million, make them available to the communities, and by the way, we'd want the community to tell us how we spend these dollars, is a significant shift than most funders, and honestly us, used to do when it comes to providing resources to the communities. Lots of policy work in those communities around tobacco, obesity. I'm sure there'll be lots of conversations here around some of these policy systems and environmental changes, from nutrition standards and Head Starts and daycare to school PE policies, school nutrition policies, Tobacco 21, and other policies that we'd want to see. I think we're really excited about cultivating and supporting tobacco coalitions, anti-tobacco coalitions in these communities and actually across the system, for the fundamental, belief that tobacco continues to be the number one cause of mortality and morbidity in this country, but also it's a driver behind disparities. So we're really excited about some of our work around tobacco across the country, and this is not just confined to the 6 communities. This is every one of our regional health systems is working on either passing or strengthening clean indoor air acts in our communities, strengthening our tobacco-free campus policies to include e-cigarettes, and doing a push towards Tobacco 21 in every one of our communities. It's interesting because we celebrated a few months ago South Bend, Indiana, passing a strong Clean Indoor Air Act. And, we're so excited because that ordinance kept going back to City Council there year after year and kept failing. So when it passed with the significant engagement of our health system in South Bend, we actually celebrated it, and we sent a note to everybody in our system and highlighted the effort there. And I can't tell you how many emails and calls I gotten, including from our CEO, saying, well, do people still smoke in, bars? And, when you live in an urban environment that have passed already these policies, you'll be surprised. So this is a snapshot of within our system where the areas of opportunities are when it comes to tobacco policy. And we've identified those from the system office, and we're working very closely with these regional health systems to make sure that we're highlighting that work and we're pushing it forward. So lots of work on the Clean Indoor Air Act piece. Tobacco 21 is another area that we're pushing really hard, according to the Institute of Medicine report that was released last year or the year before. Raising the minimum age to selling tobacco from 18 to 21 is projected to have a significant impact on healthcare costs, healthcare outcomes. 25% reduction in smoking initiation for kids between 15 and 17 years of age, 12% overall drop in smoking prevalence, and 10% reduction in smoking-related deaths. And on the immediate short term, the short-term impact, 12% decline in premature births and 16% decline in SIDS. And again, those last 2 numbers, this is immediate return for us as a health system. So not just it's the right thing to do, it has, on the total cost of care, it has a significant impact. So we've been pushing and supporting communities in their Tobacco 21 efforts. I love this slide because, for somebody who's worked on tobacco policies with Mayor Emanuel in Chicago for 5 years, I love the progress that we've seen here. So since January, when we said as a health system, we're going to be actively engaged in the fight with tobacco activists, with anti-tobacco coalitions, we've seen lots of progress. I mean, in New Jersey, the bill made it all the way the Tobacco 21 bill made it all the way to Governor Chris Christie, who pocket vetoed it. He was running for president at the time. Chicago passed the Tobacco 21 policy, plus many other historic measures, really, and our health system there was actively engaged in making sure that we're talking to the community members. South Bend is strengthening its Clean Indoor Air Act. We did a congressional briefing on Tobacco 21 together with the Campaign for Tobacco-Free Kids and the National Association of City and County Health Officers. So we were an integral part of that briefing. Albany County in New York passed a bill. It's not signed yet on Tobacco 21. We expect it to be signed soon. Again, our hospital system there was actively engaged in that. Lots of work in California, who I know you've been following there. Lots of great historic tobacco bills were signed just recently, I think on May 10th. And in Illinois on May 18th, Tobacco 21 passed the Senate, and we were actively engaged in that. So for policy wonks here, to see that much progress in such a short period of time is just amazing, and for us to be part of that process makes it even more fun. So again, as a health system, as we make that shift from healthcare to population health, you'll see, I hope I was able to give you some practical examples of how we as a system are looking into that shift and how we're embracing it. I think we have a few minutes for questions and answers, so I'm going to stop here, and I don't know if we have mics or we'll have 2 mics. So I think we have 10 minutes for questions and answers, so I'm happy to take questions and give answers. Or the other way around, too. All right, if you raise your hand, and then there are folks with the mics. Okay, Maris has a question.
Bechara, hi. Could you talk about the change management processes that are going on within your system? This is a massive reorganization on multiple levels, and how is that being rolled out both within your system and to the communities that you're serving? How does that change management occur?
Right. So, doing this work is not easy at all. I mean, when you are part of a health system, a 160-year-old health system that's done business in a certain way, it's really hard to make that shift. But for us as Trinity Health, we had 2 things that are going in our favor. The first thing is we, as a system, as I've showed you in our mission, we're really an organization about transforming communities. So when you build that movement around transforming communities, you're going to get lots of excitement and lots of support. That's why a lot of our people who come to work for Trinity Health focus on that. The other piece, I think, that gave us really the big momentum to be able to getting things done is that commitment from our CEO on embracing that shift from being a producer-centered system to a people-centered system. And we've made a commitment that by 2020, 75% of our revenue will be coming from alternative payment models. What that means is we are taking that leap of faith and saying we will get to a point where we are responsible for the total cost of care for these communities, and we need to do whatever it takes so that we make sure that we're successful and sustainable in that environment. So that really created that push in creating that excitement. And I can tell you, I visit with our regional markets all the time, and that type of work is so exciting to folks on the ground, and the way we interface with the community is becoming more and more different, and really becoming more of a, we're here to provide resources and be part of the solution. We're not necessarily the only solution in town.
Hi, Bechara. Leslie Mickelson from Prevention Institute. I would love to hear, especially since you are a public health person, I think some folks in public health feel a little nervous to hear that hospital systems are getting involved in community health and well-being, even though I want to say personally I think it's fantastic. But I wonder if you could comment on that division of labor and sort of what does the hospital bring and what does public health bring to that partnership?
Right. Thank you for the question. And I have to tell you, and I think Denise mentioned that in her opening remarks, one of the things that I regret I haven't done enough of when I was the health commissioner in Chicago is even though I feel like I've done a lot more than most other health commissioners have done, and I still think that we didn't do enough, is that, getting to know health systems, getting to know how they operate, getting to understand, ACOs and bundled payments and Medicare for Medicare shared savings programs and next-gen ACOs and SIM. I don't know how many of you are involved in the state innovation models. If you're not involved and you're a public health person, please, please, please be involved. I mean, I think that understanding would alleviate a lot of the fears. The reality is, unless we really come together in practical steps, and identifying very specific steps and very specific initiatives and projects, we're going to still continue to be these very scary environments, on both sides. I don't think healthcare systems in general have spent a lot of time understanding what public health can offer, and I can assure you from my 5 years in Chicago, we didn't spend as a public health system enough time to understanding what the healthcare providers can offer. And that interface is so rich and so, there's lots and lots of opportunities there. And I hope those specific examples that I gave would kind of allow us to understand how that relationship would work better.
Thank you.
Thanks. Yes.
So this is not a trick question, but it is a tricky one. We work with you in Muskegon where you are the major provider, and that's great because you really do have an incentive for the entire community to be healthy. How does it work when you're not the major player? It's one thing for public health and providers to collaborate. It's another for providers to collaborate among themselves. How do you do that?
Right. So thank you for this question, Esther. And this is an important question. And in reality, in many of our markets, in most of our markets, we are not the only provider in town. The Muskegon example is one of very few where we are the only provider in town. But I think our approach has been, especially when it comes to community health and well-being, we're in it together. Like when we launched the request for proposal, we encouraged our local leadership to actually talk to other health systems and make sure that they're engaging them in that effort. And the best example to me is in Boise, Idaho, when we announced the awardees. We had, the Boise community was so excited about, getting this commitment for the next 5 years, and they had a community event at one of the schools where, the awardee there is the Treasure Valley United Way. And when we went to that event, we had our CEO, our CFO, a couple of our board members, but we also have our competitor CEO, our competitor CFO, and believe me, it's a very, very competitive environment. And I'm not saying, I'm not, revealing a secret there. We are suing each other there in Boise, and we have court cases and all of that. But when it comes to community health and well-being, our competitor CEO and CFO were at the release of that announcement. Because when it comes to community health and well-being, we really need to be thinking more collaboratively than competitively. Yes.
Hi, Steve Shannon with the Colleges of Osteopathic Medicine. I'm interested in the role that education plays in this as you roll out this transformation in two senses. One is the health professional students, no matter what profession they are, that are training within your system, and how that is either engaging within this type of change or inhibiting it, or what your experience is. And the other is how you are going about educating the current existing health professionals that work within the system to work as teams in a professional way.
Yeah, right. And this is a very difficult question to answer, and I don't know if I'll have the right answer, but within our system, we have 2,000 plus residents across our system. Loyola University is part of our family, so we're really excited about that partnership, that relationship there, and we're learning. I mean, we're in the process of trying to understand what does it mean to be engaged and actively engaged with a medical school, with a health profession schools there at Loyola. We're really looking at how we're training our residents across the system. I don't know we have the answer to this yet, but we're trying, and I'll be happy to share this as we, as this continues to evolve. I don't have a full answer to that question.
How about your current practitioners? How are you working with the teams within you?
Oh, so on the shift, we spend a lot of time, especially when it comes to our clinically integrated networks. So every one of our communities has its own clinically integrated networks that look at our care model, our care management approach that looks at how we provide services, and we do lots of training, and we get lots of data, share lots of data with providers to try to see how we can improve the care experience, improve the care outcome, and lower cost for our patients, especially in our ACO infrastructure. We've looked at care management. At first we had, we have 25 regional ministries, and we had different care management models in each one of those, and now we're in the midst of coordinating and really standardizing our care management approach. So that's one example, and that's not just on the hospital or outpatient side, but also on continuing care. So care management across the continuum is one work stream that we're using as a way to help us provide that training and the engagement of our providers at the local level. Yes.
Hi, Bechara. I'm Elizabeth Sobel-Blum with the Federal Reserve Bank of Dallas. A couple questions. First of all, can you talk more in detail about how you engage with the community development and economic development sectors? So not just CDFIs, community development financial institutions, but CDCs, meaning community development corporations and others. And then second of all, in community development, we talk a lot about low and moderate income communities, but I think it's very much tiptoeing around the issue of racial inequalities. So how are you addressing equity in all policies?
Great. Thank you, Elizabeth. The experience of getting community development as an integral part of our Transforming Communities initiative was not an easy process. I think when, during my tenure in Chicago, we were engaged in a lot of these community development organizations and community development work. That's because of what local government is all about. It's about community development, education, and public safety. So we spent a lot of time there. When we started talking to our community partners, our traditional community partners in our markets about community development being an integral part that goes hand in hand with community health, it was very difficult. It still is very difficult. And that's why we're engaging IFF and TRF to help us in that conversation. I remember when we issued the RFP, we said, we want folks to apply for grants, but also have a roadmap on how to apply for the loans. And I can't tell you how many phone calls we've gotten and emails my team has gotten about saying, well, we only want the grants. We don't get us concerned. I mean, we don't want to have to deal with the loans. And we said, no, we want to make sure that this is an integrated effort. And we'll see how that's going to evolve over the next couple of years and see if they will be able to tap into the community development resources. I don't know how this is going to work. I'm hopeful that this will be a successful process, but we'll see. I mean, it's going to be an example. The question regarding health equity, one thing that we're working on is really a roadmap to health equity for our health system, that by 2020, we are identifying very specific concrete steps that we'd want to take as a system to help us advance health equity between now and 2020. And we've identified a bunch of these steps that we want to take as an organization ourselves when it comes to our board leadership, our talent management, recruitment, our supply diversity and other stuff that we want to take as an organization. But also we've identified very specific steps on the clinical side that we'd want to take to help us advance health equity. And then we've identified things at a community level to take to advance health equity. So we're finalizing that roadmap. It's going to our board next week, and in June, and I'm hoping that this will be finalized. We'll be happy to share it once it's final. I'm giving here a note that this is the end of this session. I'll be around for a little bit to answer some more questions offline. Thank you so much for having me, and I hope this was what you were looking for.